So we're going to talk about blood pressure, both in regards to shock and also in regards to hypertension. So strap in. So Glennis Fitzgerald is a 22-year-old woman. She just delivered her first baby 2 hours ago. She's starting to feel pale. She's starting to feel weak, or look pale, I should say. Her pulse has gone up to 130. Her blood pressure is down, and she is having a lot of vaginal bleeding. So, obviously, those of you that are obstetric minded have an idea of what an intervention might be. But let's think about what maybe are the issues in managing her blood pressure. So the equation for blood pressure is cardiac output times systemic vascular resistance. And the formula for cardiac output is heart rate times stroke volume. So stroke volume is affected by fluid volume, by filling time, and also by muscle function, and also an intact mitral valve, because you can have a pretty good ejection fraction, and then if it's all going backwards, it's not going to be helpful. So basically, this is similar to the concept of flow equals pressure and resistance. So what can we do if we're trying to raise her blood pressure? Well, we can affect this equation in a number of different ways. Before we talk about that, though, let's review for a few items. Systole is what the heart is doing when it is contracting. Diastole is what the heart is doing when it's relaxing in between beats. Pulse pressure is the difference between the two, the pressure at systole versus the pressure at diastole. And obviously when we measure it, it's called the systolic blood pressure or the diastolic blood pressure. Mean arterial pressure is that pressure that exists. Now remembering that the heart only is beating about a third of the time and 2/3 of the time it's resting. So that gives us an idea of what the equation might be for mean arterial pressure. We need a certain mean arterial pressure to perfuse our organs. Heart anatomy, we'll review that in a little bit, but basically, it comes up through the vena cava, goes into the right atrium, goes through the tricuspid valve, into the right ventricle, and then out through into the pulmonary artery, and then into the lungs, and then through the pulmonary vein, back into the left atrium. Don't forget that there's a little projection off the left atrium called the left atrial appendage, which is important as far as pooling of blood. Goes through the mitral valve, and then out the into the left ventricle, and then out through the aortic valve. Didn't mention the pulmonic valve, but obviously that's the valve that it goes out of the right ventricle with. Preload is basically the amount of pressure that's on the heart before it beats. And afterload is the amount of pressure it's beating against. That's a little bit simplistic, but it basically does summarize it. In my simple little mind, preload is really a function of how much fluid is in the body, and afterload is a function of arterial tone. Primary hypertension is hypertension that we don't have a reason for. Secondary hypertension is due to something else, whether it be hyperthyroidism or some other endocrine problem, but at any rate, it's secondary to something else. And then orthostatic hypotension is when you stand up quick and all of the fluid pools in your lower extremities, and the blood pressure down there is just fine, but the blood pressure up in your brain is low, and you start to feel a little woozy and have symptoms. So, what does the body do? Well, the sympathetic nervous system kicks in, that fight or flight. Heart rate goes up. Stroke volume also tends to go up. You can give people extra fluid. They'll try to retain their fluid. Their kidneys will decrease excretion. The problem, of course, is that if the heart goes too fast, the ventricle doesn't have time to fill up, and the heart output will actually go down. Muscle function, if you have damage to the heart muscle, then obviously the amount of ejection is going to decrease. And then peripheral constriction. If the periphery clamps down, there's more fluid that will be returned to that right atrium. And so all of those things happen with Glennis, and then the question is it working? Well, maybe yes, maybe no. When someone does not have enough blood to perfuse their vital organs, usually but not always associated with hypotension, we call that physiologic shock. Now they talk about the stages of shock. The next slide talks about that. I'm not sure that they're really stages as much as they are classifications, although they do happen sequentially. They don't always happen in that sequence, or I should say they often stop at one and then go back. And then the types of shock, what kinds of things can cause shock. So the stages of shock. In that early stage, the pulse goes up a little bit, the blood pressure goes down a little bit. Generally, we're going to try to fix that. And so the body is also trying to compensate, and so it is compensatory in that compensating phase. Sometimes the compensating doesn't work, and the shock will progress, and occasionally it gets to the point where you can't reverse it. Again, I don't find incredible utility in this classification, but it is something you'll see talked about. What kinds of things cause shock? Well, if you don't have enough volume, if you've lost blood, if you're profoundly dehydrated, you're hypovolemic. Often you'll get orthostatic hypotension when you're hypovolemic, when you're dehydrated. You can have an obstructive shock, cardiac tamponade, if you have fluid that builds up in that pericardial sac. So normally there's really no fluid to speak of in that pericardial sac. If it builds up, the problem is that it increases pressure. The heart has to beat against that pressure, and eventually sometimes the pressure in that pericardial sac exceeds the ability for the heart to beat, and you can actually die from this. You can have a pneumothorax, you can have a dissecting aneurysm, you can have a pulmonary embolus. All of those things will cause obstruction in the lungs so that the fluid is not flowing the way that it should be. Now, distributive shock is basically you got enough fluid in the body, but it's in the wrong place. Very frequently, this is related to dilatation of peripheral vessels. That's what happens with anaphylaxis. You get red, swollen extremities, and all of the fluid is out there, and therefore it's not going to the important organs. Septic shock does something very similar. Neurogenic shock is usually related to spinal cord injury in which you have vasodilatation of the lower extremities. Cardiogenic shock, of course, is damage to the heart where the heart is not beating as well. So again, let's go back. Blood pressure is determined by cardiac output, systemic vascular resistance. So we could try to affect the systemic vascular resistance. We could try to give a pressor. The problem with pressors is that they often also decrease the amount of blood flow to vital organs unless they're very carefully titrated. Cardiac output, we could try to increase the heart rate. It does increase on its own lots of times. Or we could try to increase stroke volume. We can increase stroke volume by giving increased fluid volume, sometimes by slowing the heart down if it's going too fast. And there are some medicines that actually do strengthen the muscle of the heart. They're called inotropes. Chronotropes change the rate of the heart. Inotropes change the strength of the heart. So we could do any of those things. So basically we're going to give Glennis fluids. We're probably going to try to have her secrete her own hormones, which will cause a vasoconstriction by massaging her fundus. And usually we can get her to clamp down and the bleeding will stop. So give her fluid, and the renin-angiotensin system is going to try to retain it. Aldosterone is the name, sodium retention is the game. You retain sodium. Sodium will cause you to retain fluids. So crystalloids are regular IV fluids. Colloids have proteins in them. So basically it's TPN or blood products or plasma. Not very commonly given, although we might actually get to the point where we need to give her blood to allow her to carry enough oxygen. She's going to increase her heart rate. I don't think there's any value for us trying to increase our heart rate because the body naturally does this. In fact, we sometimes have to slow it down. So yes, we can do pressors. Vasopressin is an option. There's other pressors. And again, the challenge with pressors is you may be sacrificing one organ for another. The challenge with the dopamine drip is you have to be very careful to give it at a level that it increases kidney perfusion, which is usually the low levels, but that's often not sometimes enough to maintain the blood pressure. So some people actually try to use dilators with hypertension, with shock. They decrease oxygen need, they keep the main organs perfused. The challenge of this, of course, is that you need to maintain that mean arterial pressure at a level that is adequate to perfuse the vital organs, and if you're dilating it, it just becomes that much harder to do. Got to remove the cause. Whatever the cause is, we got to remove it. And if the body's confused, and there isn't any problem with bleeding or low blood pressure, sometimes the sensors of the body feel like the blood pressure is not high enough when in fact it's normal. Thus, they will put out things like renin and angiotensin, and they'll increase those things and end up causing a high blood pressure or hypertension. So primary or essential hypertension is the one that has been around for many years. Back in the early 1900s, we thought that there was a reason that these people had to have a high blood pressure, and so they referred to it as essential hypertension. In fact, though, we now know that that's not true. There's so many of those things that are just left over. Secondary hypertension, again, estrogens can do that, renal disease, etc. The renin-angiotensin system is probably the mainstay of treatment for hypertension at this point. We can block renin with aliserikarin. It's a direct renin inhibitor. The challenge is it's expensive, it's relatively new, we don't have a lot of research on it, but it is available. We can block the angiotensin converting enzyme, which causes the angiotensin 1 to be converted to angiotensin 2. Angiotensin 2 causes vasoconstriction and also stimulates aldosterone secretion. Aldosterone is the name, sodium retention is the game, and that will increase your circulating fluid and raise your blood pressure. Angiotensin converting enzyme is found in the lungs, and this is why if you have somebody that's on an ACE inhibitor, sometimes they'll develop a cough and end up with that kind of a side effect. So renin is secreted by the kidney. I always say renin. Renin is a different hormone that is produced in the gut that's a digestive hormone. And so, again, sometimes the kidney is confused. Sometimes diabetes has affected it. Sometimes there's actually a stenosis of one of the renal arteries, and you end up with problems. So you got to usually try to block the effects of the angiotensin. Now, I will warn you that if someone has a renal artery stenosis and you block the angiotensin, it does confuse the kidney, and the kidney will actually start to fail and get very high potassium. So this is why we check blood levels of electrolytes a few weeks after starting an ACE inhibitor, just because if you have somebody with a renal artery stenosis, it can cause real problems. So here's the basic chart where an ACE inhibitor works, where an angiotensin receptor blocker works. Obviously, that blocks not only the aldosterone, but also the peripheral direct vasoconstriction that would occur with angiotensin 2 and actually causes a vasodilatation. Mild, not as dramatic as a lot of other medications would do. So ACE inhibitors decrease the circulating volume by decreasing that aldosterone level, so they decrease preload. They also do have a little bit of vasodilatory effect, so they decrease afterload. So this is great for hypertension, but it is also a great utility for heart failure. And we'll talk about heart failure more. So the side effects, again, if you've got a renal artery stenosis, that can cause a high potassium or BUN creatinine. Another common side effect is cough, again, because the enzyme is located in the lung. The ARBs, or angiotensin receptor blockers, block angiotensin 2. There's fewer side effects, but they're basically the same. Cough occurs maybe in 1% as opposed to 15 or 20% at least of ACE inhibitors. They're a little bit more expensive, although many of them are now generic, so there's little or no difference in the cost. A lot of the early research was done with the ACE inhibitors, so we had a little more data on them, but there's a lot of good data with the ARBs as well. We could directly block aldosterone. We could use an aldosterone receptor antagonist, or an ARA. Spironolactone is probably the most common one used. Eplerenone is probably better if you don't want the hormonal effects, because spironolactone will actually block the effect of testosterone as well. So that makes it a utility medicine, or a medicine of utility in things like polycystic ovary syndrome, someone with hirsutism, but it also will block that aldosterone, so therefore it will not cause sodium retention. It will cause sodium excretion and will lower the blood pressure. There's other diuretics. There's potassium depleting diuretics like the loop diuretics or the thiazide diuretics, but there's also some potassium retaining diuretics besides the ARAs. And they all change absorption in a different part of the nephron. I'll let you look that up in one of the textbooks. I don't think it's particularly important to know exactly where which one works, other than to know that they do work in different places and therefore have different effects on the electrolytes. Other ways we can decrease the blood pressure, we can slow the heart rate. So beta blockers will lower the blood pressure. Calcium blockers, most of them will slow the heart rate. The non-dihydros like amlodipine is a little bit less likely to do that. The dihydro calcium blockers will actually decrease muscle strength to the heart, which really makes them kind of questionable medicines. They do lower the blood pressure, but they don't have great data on any other outcomes, probably with the exception of amlodipine. Amlodipine does have some evidence for positive outcomes. And we can also vasodilate. There are some specific vasodilators. They're more the old-fashioned medicines like apresilene and things like that, which we do sometimes still use for pregnant women, interestingly. So how can we lower the blood pressure? Sympathetic blockers, beta blockers will slow the heart. Alpha blockers will cause peripheral vasodilatation, because an alpha stimulation would cause vasoconstriction. Parasympathetic stimulation would work, but there's so many side effects from it that we really don't usually use that. We can block the renin-angiotensin system in the various places we talked about. We could use calcium blockers. We could use diuretics, or we could use vasodilators. Secondary hypertension, again, renal artery stenosis is a common one. A FeO is something that you'll probably only see a few in your life. These people have dramatic elevations in their blood pressure, although it may be paroxysmal. Paroxysmal means it kind of comes and goes. And so if you have somebody that's 200 over 120 one day and 140 over 90 the next day, one of the things that might happen is a FeO. They're not that easy to diagnose. We usually think of them happening in the adrenal medulla, but they can happen elsewhere as well. All right, mean arterial pressure. You can't just average the systolic and diastolic, because the heart is in diastole longer than it's in systole. So the usual is to double the diastolic blood pressure, add the systolic blood pressure, and then divide by 3. An example of ways that we use that mean arterial pressure, the cerebral perfusion pressure is usually about 70 or so. You want it to be at least that. And so the mean arterial pressure minus the intracranial pressure should be at least that. So if you have somebody that has high intracranial pressure, you're probably going to need to maintain their blood pressure a little bit higher so that they will perfuse. This is one of the reasons, interestingly, after acute head injury or cerebral insult, that we sometimes will allow these people to run a little bit higher blood pressure. Vasopressin, also known as ADH or antidiuretic hormone, causes vasoconstriction, has an antidiuretic effect. It's actually kind of a fascinating medicine. Now, hypertension is something that I find very difficult to keep up with all the different classification systems. For many, many, many years, we actually had the JNC, the Joint National Committee, number 7, that had come up with these guidelines. And a lot of people have memorized these guidelines. Normal is less than 120/80. Prehypertension is 120 to 140 or 80 to 90. Stage 1 was anything over 140 or anything over 90, up to those numbers that are shown, the 159 and 99. And then stage 2 was higher than that. Well, the problem is we now have competing sets of guidelines, and this doesn't even include the European guidelines. I've just included the American guidelines. So in about 2014 or so, JNC 8 came out. It was December of 2013. And it basically said that we're not going to worry about classifying stage of hypertension, stage 1 to stage 2. We're actually just going to say people are either hypertensive or they're not. And we're also going to liberalize a little bit. For people over 60, we're going to say that you're not hypertensive until you're over 150, over 90. There's some data that would suggest that overall mortality outcome does not change until you reach that level. The problem is the cardiologists didn't like this because they're not worried about overall mortality level as they are cardiac mortality. And cardiac mortality actually does go up with some of these lower numbers, although we have to try to explain why would cardiac mortality go up even though overall mortality is not. There are feelings that maybe people are dying from other things that maybe the medicines or the treatments are causing. So again, you can see those. In 2017, to try to break the tie. Now, the big criticism of JNC 8 was that it was done with only randomized controlled trials. They had to be big studies. And so there was a relatively small number of studies, less than 50, that it was based on. And so the cardiologists, again, didn't like this. They went back and they said, okay, we're going to come out with our own classification system. The American College of Cardiology and the American Heart Association came out with a new set in 2017. And they basically pretended that JNC 8 never existed. And so now they're saying, okay, well, the old system, which was JNC 7, classified things as prehypertension up until 140. We're not going to do that anymore. We're going to say that your normal blood pressure is less than 120/80. Between 120 and 129, and if your blood pressure, your diastolic is still less than 80, we'll say your blood pressure is elevated, but you're not really hypertensive at this point. But anybody that's over 130 and over 90 or over 90 is stage 1 hypertension according to the latest guidelines. And then anybody that's over 140 and over 90 and in that 90 to 99 range is stage 2. And they also include the people with higher blood pressure are still in stage 2. So again, for those of us that learned the old staging system, it's changed. For those people that don't accept 2017 ACC/AHA, they're basically going to go by JNC 8, and they're not going to use any staging. Gets very confusing. People have to choose up their sides. The cardiologists felt like we had to control blood pressure better, mostly based on the SPRINT study that I'll talk about in just a second. So also, though, to talk about African Americans and hypertension. It's very hard because a lot of them African Americans are not very excited to be treated differently, especially based on Tuskegee and some other experiences. We do think that on average, African Americans may have a slightly different physiology, but the problem, of course, is that many African Americans are 40% European. So it's really hard to decide what to do. Um, Many of the African Americans have a higher incidence of low renin levels, and therefore probably will not respond as well to an ACE inhibitor. But they probably are better than beta blockers in African Americans. But basically, based on most guidelines, the drug of choice for non-African Americans is usually going to be either an ACE inhibitor, a calcium blocker in the form of amlodipine, or a diuretic. But for African Americans, generally, and this is based on the All Hat study, you can look it up if you want to, basically you're going to start either a diuretic or amlodipine. That being said, if they're diabetic, you're going to want to have them on an ACE inhibitor for the renal protection, but it does get pretty complicated. So most African Americans have a bit earlier onset. They're a little bit more likely to have renal damage. Not all African Americans are poor, but statistically they're a bit more likely to be poor, so they might have difficulty with access. This may be one of the reasons that they have poorer control. Also, African Americans are a little bit cynical about the so-called white healthcare system. And again, we shouldn't, put all African Americans together, but there are some that are a little bit cynical. But we really don't know the significance of these differences. And again, I tend to take it as an individual situation. If I have somebody that's diabetic, I'm going to put them on an ACE. And then I just titrate their medicines to try to achieve adequate control. So the SPRINT trial. So this is the systolic blood pressure intervention trial. And it got a lot of play in the press with them saying the lower the better. You got to lower the blood pressure. The lower the better. And so in this study, they basically treated to either less than 120 or less than 140. So the tight group was less than 120, and the more liberal group was 140. The problem was it took 2.8 medications to get to less than 120, and only 1.8 to get to less than 140. They did definitely have more problems with hypotension, more dizziness, more acute kidney injuries, more electrolyte abnormalities, as well as acute renal failure, but they didn't have more falls. And that was the big thing that was put out is the lower the better. They have less cardiovascular events, and they don't have any more falls. But they don't mention all these other side effects. And again, you can see right here that the intensive treatment also had a disproportionate number of people, or the study, I should say, had a disproportionate number of people with chronic kidney disease. The general public does not have almost 30% of the population that has chronic kidney disease. So there was definitely, I think, a sampling issue. All of these people were over 75 or had kidney disease or had a known cardiovascular issue. So this is not the average person that's a basically healthy person with hypertension. These people have substantial risk factors. It also oversampled African Americans who make up about 15 to 20% of the population, and it had about 30% in this study. So what did you have to do to be in the study? You had to be at least 50. Again, just being over 75 would get you in the study. But if you had renal failure or if you had other things, you had to be over 50. You had to have hypertension with a systolic blood pressure of at least 130, at least one risk factor for heart disease, whether it be clinical or subclinical cardiovascular disease other than stroke, chronic kidney failure, Framingham risk factor of at least 15% based on a 10-year calculation using cholesterol and risk factors and age, and or be over age 75. So who did we exclude? Very importantly, we excluded people with diabetes. So this does not generalize to people with diabetes. And so, unfortunately, a fair number of the people with hypertension are diabetic. But if you're going to use the SPRINT study to validate more aggressive treatment, you really can't apply this to diabetics. The reason being that there was another study that was done with aggressive treatment with diabetics called the ACCORD study, which did not show a statistically significant improvement in outcomes. Okay, so let's look and see what kinds of things happen. The primary outcome. Now, this is one of my pet peeves. They tend to pool all these outcomes. This one had MI, coronary syndrome, stroke, heart failure, or death from cardiovascular causes. So basically, we're looking at cardiovascular death. We're not looking at overall death. And so when we look at it, we're going to say, okay, what were the benefits here? So interestingly, when you look at the specific outcomes, the only thing it really benefited, those are shown in yellow, were heart failure, death from cardiovascular causes, and there was a modest improvement for death from any cause. But again, this was from heart failure. This wasn't from heart attacks. It does not decrease the risk of heart attacks. In that lower green long stripe, you can see that there was a 30% reduction in GFR in a substantial number of people. In the intensive treatment group, it was 3.8%. In the standard treatment group, it was 1.1%. So again, there seemed to be some kidney damage in the more aggressive treatment group. So ACCORD, again, ACCORD is the study that was done with diabetics. SPRINT showed a 25 relative risk reduction. Now the problem is that that can be going from 1% to 0.25%. It's decreased, or I should say 1% to 0.75%. It's a modest difference. It's 1/4%. So you have to look at the overall prevalence. It does not really talk about absolute risk reduction in this article. ACCORD only had a 12% relative risk reduction, which was not significant. So that kind of summarizes hypertension. Obviously, there's a lot to know. I'll put up a couple of other talks on that, as well as we'll have a number of different discussions regarding that on the discussion board. So let's talk about the cardiac conduction system. So conduction starts in the SA node. Most of you should have learned this in undergrad, but we'll just sort of review it. Goes down the internodal pathway to the AV node, goes down the bundle, and then out into the bundle branches, and causes the heartbeat as we know. All right, now for something a little different. That's an old Monty Python transition in case you didn't recognize it. All right, so I've made up something called an idiot's guide to EKGs, and we'll paraphrase it here as a novice's guide. And basically, when someone comes in and you do an EKG on them, generally it's going to be overread by a cardiologist or by someone else, depending on where you are. In family practice, ours are not overread unless you've made arrangements with one of the other providers. So the nurse practitioners in my office read our own EKGs. Again, in the hospital, the ER, whatever. So what you really have to decide is, can I let this person out of the office? If I have any doubts, can I go over it with somebody tomorrow? So the first step is, do you even need to look at the EKG? If somebody's having chest pain, if they're acutely short of breath, you're probably going to send them anyways, right? Okay, so now I've got a low probability, stable patient, and now what do I have to see on the EKG before I can decide whether I can let them out of the office? So I'm looking for lethal dysrhythmias and ischemic changes. So obviously the lethal dysrhythmias to look for are ventricular ectopy and or a significant bradycardia or tachycardia. And so VFib, this is what VFib looks like. This patient will not have a pulse. This patient will look terrible, and you'll call an ambulance and you'll get them out of your office or call a code if you're in the hospital. VTAC, This is basically a fast rhythm. This can be either conducted or non-conducted, or can have a pulse or not have a pulse, I guess is a better way of saying it. I have seen people that had a pulse with VTach, felt a little off, but not terrible. That's a big difference within someone who has pulseless VTach. I've also seen a patient sitting in their room tapping on their leads, and it gives you almost exactly the same appearance. So first thing is, when all else fails, examine the patient, look at the patient, see how they feel, and don't panic. That's a Hitchhiker's Guide to the Galaxy reference. All right, so now that you're deciding that someone doesn't have ectopy or doesn't have a lethal bradycardia or tachycardia, you have to decide whether or not they have a bundle. Because the problem is that if someone has a new bundle, that can be a sign of recent ischemia. So if someone has a new bundle, you're going to want somebody else to look at the EKG, or you're going to want to have a discussion regarding the options before you would let them out of the office. So in a bundle, the QRS complex gets wide. It's going to be more than 0.12 seconds wide, which is more of those 3 little blocks. If it's yes, it could be either a ventricular beat or it could be a bundle, but either way, you want somebody else to look at the EKG for you. If it's a bundle, they'll have P waves usually. So a right bundle branch block. Look how that QRS complex is widened. And in V1, this is the little rabbit ears happen in V1 with a right bundle. And then QRS in V6 is going to be widened there. In a left bundle, the little rabbit ears happen in V6. And you'll see widening there of that. It's called the RS because the Q is the first downward deflection before the first upward deflection. And in most cases, you won't have that. You'll just have an R wave that goes up and an S wave that comes afterwards. In your inferior leads, you may in fact have Q waves, but most of your other leads, you're probably not going to have Q waves. And even in your inferior waves, they've got to be less than 1/3 the size of the R wave. So again, you're now looking for ischemic changes. You're looking to see that the ST segment is where it's supposed to be. It should be flat. If it's up, that's a problem. If it's down, that's a problem. T waves should be up in all leads except AVR and V1. AVR should be all negative. T wave should be down, QRS complex should be negatively deflected, and T wave should be down. That's probably the greatest utility of AVR, is that that's the first lead I look at, is I look at that, make sure they're all negatively deflected. If they are negatively deflected, it was a good placement of leads usually. If they're not negatively deflected, then you have to question whether the person that was doing the EKG knew what they were talking about. And again, Q waves should not be present. Generally, Q waves are indicative of an old heart attack, but again, you're going to look twice as hard at this person if there's evidence of old ischemia. And the R wave should progress. So in V1, it should be little. In V2, it should be a little bit bigger. In V3, it should be even bigger. V4, it should be really big. V5, it should be roughly the same size as V4, maybe a tiny bit smaller. And then in V6, it should be maybe just getting a little bit smaller. So it should progress as you go across the chest in size. So again, this is what a STEMI looks like. So an ST elevation MI, you can see that those ST segments are right up there, right? So you can see that normally the ST segment should come across like this. And these ST segments are hugely out of proportion. And so you can see, and so you've got them in, this is V1 up here. These are the chest leads. And in V2, V3, V4, they're big. You also see ST segment elevation in AVL. That's a lateral lead. Lead 1 is over here. It's not marked, but that also has ST segment elevation. And you can see the ST segments are downwardly deflected in your inferior leads. So this is lead 2 here. This is lead 3. And then AVF is the third. These are your inferior leads right here. So this is usually V1's kind of septal. V2 is kind of septal going anterior. V3 and V4 and maybe a little of V5 are anterior. And then your lateral leads are V6 and AVL and 1. So T-wave changes, you can see right here. That T-wave is deflected downward. That can be acute ischemia. It can be a number of different probabilities, but you do need to pay attention and figure out why does this person have T-wave inversion, even if they are not having chest pain at the time. Q waves, you can see this is not really a Q wave because there's an upward deflection here, right? So that's an R wave. Interestingly, if you just have a Q without an R, you refer to that as a QS. And then you can see that there's some ST segment depression here. You can see that there's ST segment elevation here. So either way, this is an abnormal EKG. And you can see that there's a Q wave here, Q wave here. So this patient has had an old event and maybe is also having a more current event. And again, R progression, small, still small, still small, still not very big, now bigger, but it really should have been bigger in V3, V4, right? So this is poor R wave progression. All right, so we have to look at it. We're looking at the septal leads, V1, V2. Way over here in V1, the T waves may be down. Anterior V3, V4, lateral V5, V6, AVL, and 1. And then 2, 3, and F are your inferior leads. And AVR checks for lead placements. So again, basically you see where the positive element is. So this is called Einthoven's triangle. V1 goes across there. V2 goes down pointing to your left foot. And then V3 goes from the left arm down to the foot. And then that was all there was for EKGs. I think EKGs were developed in like the 1930s. And for 10 years or so, that's all they had. And then with good German engineering, EKGs were developed by the Germans. They decided they would augment those leads. So you can see AVF points down to the feet. AVL points to the left arm, and then AVR points to the right arm. So that's a 6-lead EKG. Beyond that, the chest leads, V1, V2, they just march from the right side of the chest over to the left. If you have somebody that's having a right-sided heart attack, you might actually have to go over more near the nipple on the right-hand side. That's often referred to as V4R, which is the right side of the chest. We really only look for an RVMI in people that are having an inferior MI. If you've got somebody that's having an inferior MI, be really careful giving them nitro, because if they've got an RVMI, that's a really good way to put them into cardiac arrest. Okay, so the last step is you got somebody and they don't have chest pain, they don't have shortness of breath, they don't have any lethal or potentially lethal dysrhythmias, there's no bundle, there's no ischemic changes. You can probably let this person go. If there's going to be a formal EKG reading, you wait for it. If there's not going to be a formal EKG reading and you have questions, you need to have identified somebody in your office that's your go-to as a resource. And then you schedule the appropriate diagnostics. If they don't have an acute heart attack, but they've been having chest pain off and on over the past 2 or 3 months, you're probably going to do a stress test. You may or may not do an echo, either way. choosing the best stress test. There is a pretty good app out there called the Multimodal AUC, which is a good way to do that, but that's beyond this discussion. So when in doubt, do the safest wrong thing. If you have somebody and you think their EKG might be off and you're going to get given a hard time for sending them to the hospital versus give them a hard time for dying, I would rather take the crap for inappropriately sending somebody than having somebody die. So I think that sums things up. This talk's a little longer than some, but I think there's some good stuff in here. So look forward to our discussions.